move. My guest today is Dr. Ed Card, Chief Medical Officer at McDonough District Hospital. Good morning, Ed.
Good morning.
Now, I could have called you Edwin, but you said I didn't have to call you Edwin because there's really only one person that uses that terminology.
That's true. My mother, and that's the only one.
But isn't it usually when you've been a bad boy?
It's when I've been bad, yes.
Been a bad boy. Well, welcome to the hot seat. We've got a lot to talk about today with what's going on in the world. What does a chief medical officer do?
I am sort of a bridge between the administration and the medical staff. I work for the administration and work with the medical staff at coordinating policies, procedures, and decision-making with regard to the hospital.
So you work directly with Brian Deese?
I do.
You do. So, okay, are you raised in Olympia, Washington?
I was raised, split my time between Northern Illinois and Olympia, Washington. Moved back to Illinois just before my freshman year of high school.
Sandwich, Illinois.
Illinois.
How many in your graduating class?
112.
Lake Holiday?
Yes.
I spent some time. I got kicked out of Lake Holiday.
Oh.
We won't talk about that either. My mother called me Gordon.
Yeah,
So we won't go there. We won't go there. And then on to Illinois Wesleyan.
Yes, I went to Illinois Wesleyan after my junior year of high school and came back and graduated from high school. But in order to do that, I had to take every PE class every day to get enough PE hours to get my high school diploma.
Back in those days, I'm not so certain that wasn't a good idea to have us take all that PE and do those sort of things.
Would have been better not to take it all at once.
Probably. Hey, and then you went on to Southern Illinois Medical School, where you had some distinction there, did you not?
I graduated was the only distinction I had, I believe. They did keep me around for the surgical residency after that.
Great. All right, so what are the coronaviruses?
Coronaviruses are a group of viruses, and they're called that because they have little spikes on the protein envelope. A virus is a very simple thing. It's a strand of genetic material, either RNA or DNA, and in the case of the coronavirus is RNA, inside a protein shell. That's a virus. On the coronaviruses, there are protein spikes that come off of the protein envelope that attach to certain cells and certain receptors to allow the virus to enter the cell. So it looks like a crown under the electron microscopy, and so it's called it became known as a coronavirus. There are two that cause the common cold that have been around forever. There's one that came out of China called SARS a number of years ago, had a very high mortality rate on the order of 60–70%, but didn't spread from person to person very well, so that sort of tamped down fairly quickly. There's another one called MERS, Middle Eastern Respiratory Syndrome, that developed in the Middle East, and it has a fairly high mortality, not as bad as SARS was, and it continues to sort of cycle. And these are both viruses that began in bat populations and then traveled through another animal and then became infective to humans. The current coronavirus, which is SARS-2, is also arose from a bat population and then probably went through a pangolin, which is a type of anteater that's a delicacy in China, and then became infective to humans.
This is COVID-19
Yes.
you're talking about. What are the symptoms?
Symptoms are varied, and the more we learn about this virus that we've only known about for 6 months.
Sneaky, right?
It can be very sneaky. It can be just fatigue. It can be a dry cough. It can be fever, though a significant number of people do not develop a fever in the course of the illness. Muscle aches, loss of sense of smell, loss of taste due to injury to the nerves in the nose. So it's got a bunch of different things, but the top ones are probably fatigue, muscle aches, dry cough, fever, and loss of taste or smell.
How do you treat it?
There is no distinct treatment at this point. There are some medications that are being investigated. The treatment is mainly supportive. There is a drug called remdesivir that is being used. It's an antiviral. There's been a lot of give and take on chloroquine and hydroxychloroquine, but have not been proven to be useful at this point yet. So the main treatment is supportive. You provide IV fluids, ventilatory assistance if needed, supplemental oxygen, those kind of things. There's no specific treatment for it.
So if I get this in the early stages of it, I can be treated at home. I can just have bed rest and plenty of liquids.
Yeah, 80% or more of people who contract the virus and become symptomatic, it'll be a bad cold, and they'll quarantine at home, lots of fluids, medication for fever, kind of just wait it out. And the vast majority of people, that is what happens.
What happens when it moves beyond that?
Well, there's a subgroup then who become sick enough that they require being in the hospital and getting oxygen therapy and that sort of thing. And then there's a smaller subset that end up actually having to go on a ventilator, to have an endotracheal tube put in their trachea, and then have air pushed into the lungs to try and support them. Because of the amount of swelling that occurs in the lung tissue, the lungs become very stiff, and it's very difficult to take a deep breath because of this stiffness of the lungs. And so the ventilator can overcome some of that.
So this is bad stuff when you get to that stage. I mean, the X-rays that I have seen show the healthy lung, and then they show the bad lung that's that has it, and it's just pretty grim looking. It's just nothing there.
Yeah. So we call it a whiteout, and once it gets to that stage, it is a very nasty disease. There's no question about it. And there's a significant number of people who, if they have to go on the ventilator, will not survive the illness.
Talk about those folks, who they are. Break it down a little bit. I'm sitting here in front of you. I'm 74 years old. I had base of tongue cancer. I have some respiratory issues. I assume I'm a high risk guy.
You would be a high risk guy. People over 60, which includes myself now, people with respiratory illness, people with diabetes, people with hypertension, people whose immune systems may be compromised either by rheumatoid disease or by treatments that intentionally modify the immune response.
So talk a little bit about what's going on here. We've got, I had a meeting with Brian Dietz at the hospital on April 3rd. I just gotten back from our trip to Florida, and I walked in and we had an appointment to talk about maybe doing something with this, and I went, "What's going on, Brian?" I go, "We're in McDonough County. It's April 3rd, 2020. We have 0 cases. Mm-hmm. We have 0 cases. Why are we even having this meeting?" And he looked at me and he went, "It's coming." How did he know it's coming?
Well, there's a couple of things. First of all, this is a virus which is very easily transmitted. That's why you and I are far apart right now. It is transmitted in droplets when people speak or cough or even just breathing. It is highly infective, and the current thinking is that one person gets the virus will transmit it either to between 2 and 3 additional individuals. So that, if it's to 2 additional individuals and it remains in that way, it goes up with the square of the number. So 2 becomes 4, 4 becomes 8, 8 becomes 16, and so it spreads very, very quickly. There are also a number of folks who are asymptomatic, maybe as many as 30%, and they can go around and spread the virus, not even knowing that they have it. So that is a big problem. And then historically, when we looked at how it has behaved in Italy and in Europe and in China, Korea, it is a very easily transmitted virus, and it makes people very sick. It's much more than the flu. People have sort of gotten onto this thing that, it's just like the flu. It is not just like the flu.
How is it different?
It seems to attack blood vessels preferentially. There was a study done not too long ago, and I don't want to get too much in the weeds, but they looked at lung tissue of people who had died from influenza, and most of the inflammation was in the alveolar cells, the ones that line the air sacs. In the people who had died of COVID, the inflammation was actually in the capillaries, in the blood vessels where the oxygen exchange takes place, which also would explain the propensity of young people to develop strokes and blood clots in their arteries, because it appears that the virus may affect blood vessels in addition to lung tissue and everything else. So it's a very unusual bug. The other part of that equation is that until 6 months ago, no human immune system had ever seen this. And so there is no immunologic memory that we rely on for things like, that's why measles vaccines work. That's why, the flu vaccine works. Why you get chickenpox once and you never get it again is because you have this immunologic memory. In some illnesses, it will completely prevent reinfection, but in others, it will blunt the infection enough that what would have been a severe illness becomes a much less aggressive illness.
So here we are in McDonough County. Those numbers went from 0 to we're close to 100. How did that happen? And why are we at 100 and some of these surrounding counties haven't even gone to double digits yet? And Adams County, which has Quincy, is nowhere near the number that we have of reported cases.
Yeah, I'm sure there's many explanations for that. We did have a couple of outbreaks in nursing homes, and that can run your numbers up pretty quickly.
We have way more nursing homes here than most communities of this size would have.
Yes, we do, and we're currently at 94 confirmed cases. We've had some employees at the hospital become ill. There have been a lot of sort of sporadic cases around the county as well. We've also increased our rate of testing. And one of the metrics that's used to see how aggressively the virus is spreading in your community is the percentage of positive tests. In other words, the number of positive tests over the number of total tests done. And we're hanging right at between 6 and 7%. And that's actually a very good number. With more testing, you'd like to see that down around 3. Which is when we'll know that we're testing enough people. With the resources that we have, I think we're doing a reasonably good job in our county of working through this, and Lynette Kale from the county health department has been invaluable in helping us with some of the epidemiologic questions and those sorts of things.
Why so many fatalities? Because we're at like 13, 14, 15 fatalities.
Yeah, one of the things...
Goes back to the nursing home again?
Goes back to the nursing home again. And one of the things that we did early on, and this was actually Dr. McPherson's idea, was that we contacted all of the nursing homes and found out who had do not resuscitate orders. And since there's no specific treatment for the illness, we suggested that families, if someone was at a point where they had made a decision that they weren't going to be resuscitated or go on ventilators or do that sort of thing, that they sort of sheltered in place. And so we have had a number of deaths. I think we would have had the same number had they all come to the hospital. We just would have used up a lot of resources, and people would have been in unfamiliar, uncomfortable places.
What's the difference between having COVID-19 and dying, or dying from COVID-19?
I think it's pretty much it's always a question of, it's like prostate cancer. Prostate cancer is a normal finding in an 80-year-old man, and people will die with it, not from it. And it's
thanks, more good news.
Yeah, well, you're
for
welcome.
me.
For all of us who own a prostate. So it's difficult to make that distinction. The other thing, though, that's interesting is that when you look back at the influenza deaths year over year, the numbers for February and March in Illinois the number of respiratory deaths was significantly higher than it had been in previous years. And so that raises the question, were these actually early COVID cases that were felt to be the flu and were misnamed? So, we may have many, many more cases than we know. The number of asymptomatic carriers running 30 and possibly 30%, possibly higher, means that there may be a great deal of exposure of the virus in the community.
So we could be sitting here right now and be asymptomatic, and if we got close enough and so forth, the perfect storm, we could transmit this to one another and not even know about it.
Correct.
What happens when I take we took our temperature when we came in today, had our masks on in common areas, so we took our temperatures and we're fine. What about tomorrow?
Tomorrow's a new day, and you don't know. And that's one of the reasons why we have been not testing asymptomatic people, because the test is only good for the day you take it. It provides you no information going forward. So, we haven't been testing asymptomatic people unless they are healthcare workers. If you work at one of the nursing homes that's had an outbreak, you're going to get tested.
What's this facility out at the rec center at Western Illinois University? What's going on out there? I go by, it doesn't look like it's very, very busy.
They are busy.
Fortunately.
They are busy.
They are.
Edgar Rodriguez and his crew are out there. That's the Incident Command, EOC, and it's for the area. And they have components from state police, city police, the health department, the hospital, a large number of different people. It's a coordination center so that the same information gets to everybody every day, so that there's coordination, there's not duplication of efforts, there's expertise available from various viewpoints that help coordinate the response in the community.
We talked about the fatalities. Back to that for a moment. Are the overwhelming majority of those people, are they senior citizens?
Yes. Yeah, most of the fatalities in the county have been residents of nursing homes.
We do have, when I read the paper, I do see occasionally somebody in their maybe 20s, 30s, 40s getting it.
It is an equal opportunity. It can affect all sorts of people, and there are new manifestations coming out. We didn't know about the risk for stroke in young folks with the virus until a matter of several weeks ago. There now appears to be perhaps a chronic fatigue syndrome that is associated with it, where people don't get completely well. They remain chronically fatigued for months and months before they can get over it. So it's an absolute mystery at this point. We've known about this for 6 months. We've been able to take a close look at it for maybe 4 months or 5 months. And the amount of information and research and such that's been generated in that amount of time is absolutely overwhelming. It's just amazing how much we have learned on an ongoing basis.
Why so many fatalities in the United States in terms of deaths? Over 110,000 cases. We're approaching 2 million. Is it because we're honest reporters?
It may be because we're honest reporters. It may be because we have an increased incidence of obesity and hypertension compared to the rest of the world. It may be that we have a large number, though happily diminishing number of smokers, significant numbers of people with COPD from previous tobacco use. So, we may be at a higher risk population. It may be that our very, the fact that we have a lifestyle of plenty may, in a way, make us more susceptible.
What about India? What about Pakistan? These areas that have these huge concentrations of people, and we're not hearing that it's exploded as much there as it has here. I mean, I've seen the pictures of how close these people are to each other, and I understand Brazil is not reporting anymore, but they're just through the ceiling. What's going to happen when this hits hits parts of Africa where these people are in close contact. Is this going to just wipe out populations?
It certainly has that potential. I don't want to be an alarmist. I think, in 1918, when the Spanish flu, which started in the United States, which is why we called it the Spanish flu, came through, and it came through in 3 waves over 2 years. And the first wave was bad, but it was the second wave that took most people, and it was millions. Now, we have much better medical care now than we had before, but I think it's a lesson that if something like this gets going and gets into tightly packed populations, like New York City, that it can run rampant, and it's real, and it's not something that was made up. In Brazil, the president of Brazil felt that this was just the flu, and he didn't need to take any precautions, and they are digging mass graves. I mean, it is a real thing, and we minimize it at our peril.
And here we are, and New York is opening up today, and Michigan's opening up today. The country, I just read an article that said it's too late. We're opening up again. The administration decided to open up the country. Does that not cause the potentiality of having a huge end of the first wave? We haven't gotten to the second wave yet, and the first wave could still be going through it at high numbers. I mean, I don't know whether Pritzker's right or not, but we're going to. These states, I mean, Arizona, Texas, Georgia, Florida, have opened up early, and they're having a second wave right now.
Yeah. There's certainly, there's risks both ways. There's no good choice here, and certainly there are economic considerations to be had, and the level of unemployment and people not being able to pay their bills. My own personal feeling, representing only my opinion, is that we need to be very, very careful about opening up. I look at the pictures that were on TV of that party at the Lake of the Ozarks. That kind of behavior is just inexcusable. And yet, you drive around town and you see people with, a whole bunch of people in the front yard laughing and giggling and having a good time, and I think we're going to be at risk, and I think when we get student population back in town, that we need to be ready for problems.
All these protest rallies too, the huge numbers, thousands of people in very close proximity, many of them not wearing masks. I mean, doesn't that bode the potential of having a huge outbreak? Though you also read that those are mostly young people, and maybe it won't be as prevalent there.
Right, and shouting and singing is just making a large amount of aerosol. So that I fully expect that we're going to see a spike as a result of the demonstrations. We're going to see a spike as a result of the fact that people have been cooped up for a month or two, and now they're being set free, and when that happens, they're going to overreact, I think.
And we'll all have to make our own choice whether we're going to go out and go to restaurants. We all want to support our local restaurants, and so we do carry out whatever. But whether or not we're going to want to, sit out in public and so forth is another question. We talk about opening up, and you mentioned Western. What's going on out at Western? Do you know that's there in terms of getting ready for this? I mean, football season. Are these? It's interesting.
I've had a couple of brief discussions, and we want to sit down and sort of have a plan in place ahead of time, so that if we need to isolate 200 people, we know how we're going to do that before we have to do it. But much of that is the university's decision. It's not mine, and I can discuss it with them, but in the final analysis, it's their responsibility and their decision.
And what about Mark Toomey with the local schools? I mean, same thing, or is that dictated by the state?
I do not know the answer to that question. I'm not sure how that decision gets made. I'm assuming that it's the school board and the State Board of Education, and they probably have metrics very similar to what, Restore Illinois has metrics that have to be met in order to go from one phase to the next to the next.
So you mentioned that you're employed, are you employed now by the hospital?
Yes, I am.
But you came
employed.
here in private practice in what, 70?
In 1984.
1984?
And opened up a surgical practice. I continued to do some surgery. The administrative side of things has taken up a significant amount of time with the pandemic and trying to coordinate the hospital response to that. Still do surgery. Originally came here and did a significant amount of vascular surgery, leg bypasses, aneurysms, carotids. Still do some carotids from time to time, but much of that has changed.
For people who have basic tongue cancer, you put holes in their stomachs and pull the tubes out. I did a very good job with me.
I have done all sorts of mean things to all sorts of people for all sorts
I
of
show my
reasons.
grandchildren, I'm the only guy they know that has 2 belly buttons. I think that's pretty fascinating. Yeah, I wrote down a couple of this. We talked about the cytokine storm. What's that?
Yeah, cytokine storm. This is the people who get very ill tend to get very ill sort of a bit later in the course of their illness. And they get ill because of a very robust, overdone immune response, and such that the immune response actually causes damage to the body, further damage than the virus. That immune response is in response to the release of certain chemicals that modulate the immune response, called cytokines. And when the cytokines get very high, it whips up this huge immune response, and the immune response is so overwhelming that it actually causes as much or more damage than the virus.
Talk about right here, social distancing. Does it work?
Yes, social distancing does work. The main means of spread is in aerosols. So the virus, we don't think, again, 6 months of knowledge about it, we don't think that it suspends in the air like measles does, where you can walk into the room, 2 hours after somebody with measles has been in there and still catch it. This is a different kind of thing. So the aerosols tend to drop out of the air more quickly and land on surfaces. So if we stay apart, that cloud of aerosol dissipates before it gets to where you're sitting. And you cannot catch this virus or any virus from one viral particle. It takes a certain number. We don't know what the number is yet, but it takes more than a couple of particles to start the infection.
But the advice is to stay away from spitters.
Stay away from spitters at all times, even in the absence of COVID.
How about, go ahead, I'm sorry.
And the use of masks then also does that by limiting the projection of these aerosols. It's not perfect, but it's cheap, it's easy, and we're getting used to seeing people with masks on, so it's not as unusual as it used to be. But I think, and I don't wear a mask to protect me. That probably doesn't work very well. It works some, but not as much as it protects those around me from aerosols that I'm generating. And going back to the fact that 30% of people with the virus remain asymptomatic, you really have to look out for your fellow man on this. This is what I've been telling people, is that this is really a civic duty to wear a mask. It's not about protecting me.
What about washing my hands? My wife wants me to wash my hands 100 times a day.
Never a bad idea. And the thing with the virus is that the happy birthday.
Yeah, twice.
You got to do it twice.
I got
it. Because a one-time round won't do it. There's some uncertainty now about how easily the virus can be spread from surfaces. It appears to be less, a more difficult way to contract the virus than from aerosols. But if you pick it up, what you don't want to do is touch your eyes, your nose, or your mouth, because those are the portals of entry.
What kind of changes has the hospital made in terms of procedures to deal with this?
Oh, my. In order to get into the hospital, you have to be screened. We have two tents outside the hospital. One is for specifically people with respiratory symptoms who are seeking treatment. People go into that tent, they immediately get a mask put on. If they don't have one, we will give them one. They get their temperature taken, and they're assessed. And then if it looks like they're probably not real ill, then consultation will be done by phone with the emergency room physician, and they'll be asked to come back to the drive-up screening area and get their test. If they look ill, if they're short of breath, if they've got a high fever, if their oxygen saturations are down, all of these things that we check out there, then they're taken directly into the emergency room. But the other tent is for everybody else. Get your temperature taken, have any symptoms, and then go on in. But no one is being turned away for testing. They're being redirected.
But I'm sitting here, I'm not going to run out after this interview and go have a test because I don't feel like I need a test. But where do I go, and when do I make the decision to take a test, and who should take a test?
You make that decision in concert with your primary care physician or provider and talk with them. You can get tested without a physician's order. There's a standing order at the tent, but we ask that you call the screening hotline first. And from memory, I think the number is 836-1715. It may be 1517, so please check. And they will ask a series of questions to determine if you are someone who should go ahead and get a test, or if maybe you need to talk to your physician. They also, on that call, will pre-register you. Get your information down, have a label printed out at the tent.
Sure.
So that when you come through and identify yourself, everything is in place. We can collect the swab, put it in an appropriately labeled container, and then get it sent off for testing.
Where do I go to take the test?
The south parking lot at the hospital, over by where the dialysis unit used to be. And you enter through the east entrance to the hospital, and there are signs that direct you where to go. And there are a group of people out there who will then also help you out.
How bad is the test?
I haven't had it, so I'm loath to sort of give it a thumbs up or a thumbs down, but a long cotton swab in your nose all the way to the back of your throat does not sound like fun.
Why was elective surgery and other elective procedures discontinued or canceled and until a later date? Why did that happen?
The elective surgery was canceled for two reasons. One, we didn't know how many people would be coming down with the virus, and so we had to kind of plan for the worst. That meant minimizing the number of people who come into the hospital who might be carrying the virus. We also wanted to preserve our personal protective equipment and not use it up doing cases that could be put off, not knowing again, is this going to come in like it was coming in Chicago and New York, or were we going to be relatively spared as we have been? We stopped doing screening mammography also with the same rationale, but also because we didn't want to leave women in a position where they had a finding on a mammogram and we don't know when we're going to be able to settle that issue for you. We didn't thought that would be very anxiety producing in the community. Once things have settled down now, we've been able to open up slowly. We're not doing as many cases as we used to. because it takes longer to turn the rooms over. Everyone is getting a swab test 72 hours before their operation. We've actually stretched that out to, in some cases, 5 days before their operation, but once they have the swab, they're supposed to go quarantine. You sit at home, you don't go anywhere, and then if the test is negative, we do your procedure and send you on home. If the test is positive, then we cancel the operation and reschedule for a later date.
So you're doing elective surgery?
We are doing elective surgery.
I mean, that's 79% of some hospitals' income comes from elective surgery. So I assume you need this in order to stay in operation.
We do indeed, and the hospital has taken a big financial hit by not being able to do elective cases and the things that we normally do. 25 years ago, hospitals were largely inpatient institutions. People came in, they got admitted, we did their workups. Nowadays, hospitals are about 80% outpatient. And so if we're not able to do routine procedures, if we're not doing routine labs, if we're not doing imaging studies, people are staying away from the emergency room, then that revenue is not there for the hospital, and it's caused some significant issues. And one of the things that I always sort of find, it's not really amusing, it's kind of interesting, that people are afraid to come to the hospital. If you get into the hospital, it's because you've been symptom screened, you've been temperature screened, and you're in an environment where anybody who we know does have the virus is isolated, and you have to have, it takes 5 minutes to get all the garb on to go in the room. But people have no qualms about going to Lake of the Ozarks or Walmart or any other place. You're probably safer in the hospital at this juncture. I think all the images of overwhelmed ICUs has left the impression that that's what's going on at all hospitals, and it's just not the case. It's not the case at all. I think we have had 3 people in at one time in a 48-bed hospital. So
say that again.
We've had, the max we've had in at one time was 3 patients, I believe. That's a recollection, so take it.
Sure. How many beds do we have?
48.
48. And how many for the coronavirus set aside, or are there?
We don't have them specifically set aside. We have negative pressure rooms.
What's a negative pressure
A
room?
negative pressure room is one where the airflow is from the hallway into the room and then out of the room through a HEPA filter to the outside. What that does is it keeps any viral particles that are released into the air in the room in the form of an aerosol don't go into the hallway. They get drawn out and filtered and then expelled to the outside as a means of controlling or lowering the risk of spreading the virus within the hospital.
What would cause you to reinstitute the shutdown on elective surgery?
There are very clear guidelines, and in fact, the Illinois Department of Public Health, we report in every day on the number of ventilators we have available, the number of acute care beds we have available, and the number of ICU beds we have available.
And how many do we have available?
We have 7 ICU beds right now, but Dr. McPherson and his group were able to repurpose the Senior Behavioral Health Center, and every one of those 12 beds does have the capability of supporting ventilators. Additionally, what was the OB wing when the Cater Schweitzer building was under construction on the 2nd floor, there is the capability to put 3 ventilators in there if we needed them. So our actual number that we report to the state is 7. We have the potential to have 22.
Oh, really? And we hope we don't get anywhere near that.
Right. And those and the 2 East wing has been converted so that there's actually an anteroom there, so that whole wing could be used for COVID patients. And that's Dr. McPherson worked with some of the supervisory folks at the hospital to get all of that accomplished for us.
What's interagency cooperation?
Interagency cooperation is what the EOC is about. It's about making sure that the hospital, the health department, the police departments, public safety at the university are all getting the same information in the same way. And we have what's called incident command at the hospital every Friday. And we have representatives from all of those institutions who come to that. We present out what we're doing. And there have been some very spirited discussions about what the right answer was going forward. But by getting everybody in the same room, getting all the agencies together, we've been able to coordinate that response, I think, really remarkably well.
What about stockpiling as an individual here, myself, and do you need to stockpile, or do you wish you'd stockpile certain things that you hadn't stockpiled?
Oh, there's a whole bunch of things I wish I'd done yesterday, or hadn't done. The current part of that incident command report out is that we have number of days on hand for masks, number of days on hand for gloves, for N95 respirators, and for isolation gowns. And it's reported out with the current hospital census, and what would it be if we had a hospital census of 40 with 5 people on ventilators. So that we keep track of that very carefully. It's reported out on a regular basis. If we can get PPE, we get it.
And what is that?
Personal protective equipment.
And again,
gowns, masks.
You get that from whom?
We get it from every place we can get it. We've gotten some from the state. We've gotten some from FEMA. We've gotten some through our regular channels. We've gotten some by the people in purchasing at the hospital, aggressively seeking out new providers so that we can have this on hand, because if the floodgates open, it happens very quickly.
What about unintended consequences where, other cases of other diseases have gone down because of such spirited attention to this stuff, or has healthcare diminished a little bit because you're so busy taking care of this?
I think there are a number of parts to that question. I think there's very clearly fewer people with acute strokes and acute heart attacks coming to the emergency rooms because they're afraid of the emergency room.
Correct.
And I think that's a disservice to the community, and that's why I say you really, if you're going to go somewhere, go to the hospital. They screen everybody who gets in. And anybody who's even marginally questionable gets isolated immediately. So I think it is safe to go to the emergency room if you need to go there. As always, if you don't need to go to the emergency room, don't go. But if you're having chest pain, if you're having stroke-like symptoms, go take care of yourself. The other thing that has suffered some is preventative care. People with hypertension, people with COPDs, other issues that need ongoing care. And we initially, again, preparing for the worst, cut down on the number of visits to primary care. We're in a good place now. The level of transmission in the community is low, and so we're now encouraging people to come back. You'll need to be screened before you get in. We are stretching out appointments so that we don't have lots of people sitting in waiting rooms. So we're trying to get back to that kind of care, which is essential.
I mean, like people like Biagini sitting there, I assume with a list of people a mile long who do need to get in for colonoscopies, and some of those people you're going to find out need to have attention because you're going to find something in there that they wish they hadn't found. But yeah. So we need to get people back doing these things.
Yeah, and I think the hospital and the clinics have worked hard at making a return to the clinics as safe as possible. They've also done a lot of work with telehealth and doing visits either on the phone or video chat visits. So we're working hard to try and make sure that we're providing to the community the things that they need, and that we're doing so in the safest possible environment.
I'm sensing that you're optimistic, that we're in good shape to deal with what's been thrown at us so far.
I think we're in a good place right now. Things have sort of plateaued. I think we are as ready as one can be for a second wave.
And is that coming?
In my opinion, I think it's inevitable. I think, we have the yearly flu season, and that's not going to go away. And then you add this on top of it, it seems it may well have some seasonality, and if that's the case, then in the fall, it will likely return.
Vaccine?
Hope so. Still a ways to go on that, and lots of candidates, but no clear this is going to work.
And how are you going to get that out to 330 million people?
I'm glad I don't have to figure that out.
On top of the flu shot?
Yeah.
So I know I get my flu shot and my COVID.
That's going to be a huge issue because it's not 330 million people. It's 5 billion.
Right. Worldwide, yeah.
So, it's going to be a logistical nightmare. And I'm very, very happy that that's somebody else's decision to make.
I'm a handshaker. Will I be able to shake hands again?
No, we're just going to kick feet.
Not sure. Hey, let's talk about you a little bit. Your parents, what did you learn from them about life, or what life lessons did they teach you?
My parents, my father was a machinist. My mother got her GED 3 weeks before I graduated from college. So they were very blue-collar folks. And one of the things that they very clearly taught me was a work ethic, that if you come to work, you work. And somebody pays you for an hour's work, you give them an hour and 5. So lessons that were very good in that sense. There also was a very strong streak of doing the right thing, even when it wasn't necessarily the easy thing. And we all fail at that. I'm certain that I have failed at that many times, but ongoing try is what matters.
Why did you become a doctor?
The simple answer is that our freshman year in high school, there was a test that we took looking at things that you liked and didn't like. And I came up with being with people and science. And those two things said, well, I'll just go be a doctor. As I worked through that and went to college and learned more about it, it became more and more intriguing. I spent one summer working as the only male aide on the day shift in a nursing home. So I did all of the things that nobody else wanted to do. And even through that, I enjoyed the interaction a great deal. And when I went through medical school and did family medicine, I thought that was interesting. I did OB, and no, I wasn't going to do that. And pediatrics was okay. The kids were great, but there were mothers and there were fathers, and that wasn't so much fun. And then when I hit surgery, it was like, this is what I want to do. This is fascinating, difficult, challenging, and has the potential to do a great deal of good for people. So,
Why Macomb?
When I finished my residency, my wife at the time wanted to go to a town with a university in it. I wanted to go to a smaller town. And I ran into Rick and Monica Iverson at a doctor's fair in Springfield when I was chief resident. And I said, hey, you guys need a surgeon? And they said, well, we might be able to use one. And so I came over.
I've told the story before, but when I was finishing up my time with Dr. Iverson as my doctor and he was moving on, he asked me, looking for a softball to have me say something nice about him, said, how did I do as your doctor? And I looked at him and I went, not very well. And he got this kind of pained expression on his face. And he goes, what do you mean? I go, well, when I first came here, I Didn't have any gray hair. I didn't have love hand. I didn't have love handles, and my body was considered to be higher than it is now. We had a good laugh because wonderful doctor, great. He and Monica are wonderful, great assets to the community.
When I started my practice, I was on the second floor of the health services building, and IBM, Iverson, Baker, and McPherson, were right down the hall. And those guys saved my bacon on numerous occasions because I was trying to start a solo practice and had not even a clue of what I was doing. So,
Well, you knew what you were doing. You just didn't
not
need
from
some
the
cases.
business side of it.
What's the best advice you ever got?
Best advice. It's probably the advice that my father gave me about, work hard and exceed what people expect you to do.
What's the future of medicine?
Hopefully retirement someday. I think medicine is becoming increasingly technologically dependent. I think the telehealth is going to be more and more of an issue. Procedures are becoming less and less invasive, more laparoscopic, abdominal things, thoracoscopic in the chest. I mean, they can take out a lung with a scope now.
Wow.
I don't know if the robot is going to be all that it's purported to be. It's certainly very good public relations at this point. I don't know if it's going to radically alter the face of surgery. But I think that's, and as new medications come along, and a lot of these, what are called monoclonal antibodies that are very targeted, very specific for different illnesses and tumors and things, I think it's going to be a very interesting time in the next 5 to 10 years.
25% of rural hospitals are in danger of going under. I mean, it's a very scary situation. Why is that happening, and what will we do to stop it from happening?
I think it happens because the patient base is smaller, and so your revenue and expenses are a little closer together than if you're a big system with 7 or 8, 400-bed hospitals, and you can get some economies of scale. We have managed to stay independent because of fairly careful financial planning in the past, and we've had to make some difficult decisions in the face of the current financial situation, given the drop in revenue that we've had. But it's hard. It's difficult for small hospitals to stay viable.
Has it been necessary to furlough people and so forth?
We have furloughed some people. We've had some layoffs as well.
Hope to bring them back, or
we do hope to bring them back.
What does Ed Card do for fun?
I have a wood shop next to my house, and I build furniture, which I always figured that if I could sew 2 4-millimeter vessels together and have them still have blood go through, that I probably could pound a tenon into a mortise.
If you could have dinner with some famous person, living or deceased, who would that be?
Dinner with John Kennedy might be interesting. Lincoln would be fascinating.
Yeah. How about, you got a favorite movie?
Oh, yeah, I like silly movies. Young Frankenstein and
Gene Wilder?
Airplane and,
Yeah.
just.
Those are silly movies.
Those are silly movies.
What are you proudest of?
I think what I'm proudest of is almost 36 years in a community. And when I came here, my goal was to try and make the surgical care in the community better. And I think we did that. I think the addition of vascular lab testing, the vascular stuff that we did, general surgery quality, I think got better in that 36 years. And I owe a great deal to the community. They have been incredibly kind and supportive through that whole period of time, and to the other physicians in town who have also been kind and supportive.
What do you hope your legacy will be?
Oh, that, I did right by as many people as I could, and that I left the place maybe a little better than when I found it.
Any closing comments for our viewers on how the what we should do about COVID-19 as a community and as individuals?
We have to look out for one another, and that's what the mask is about. That's what the distancing is about. It's what, all of the mitigation factors are about, is looking out for one another, making sure that we're not putting our fellow citizens at risk by our behaviors.
Do I need to wear the mask when I'm out on a walk, or do I need to wear a mask when I'm in a building?
If you're not in close contact with people, then you probably don't need the mask, particularly if you're outside. But have it with you, and if you come into contact, then you need to put it on.
Anything else?
Not that I can think of.
This is the time when I generally reach across and shake your hand. But the last thing I heard this morning from my wife was, do a good job, be relaxed, and don't shake anybody's hand. So I'm not going to shake your hand. But Ed Card, thank you so very much for taking time from your extremely busy schedule to be with us here. And to you folks, thank you so very much for taking time from your schedule to join us here on Macomb on the Move. And I hope you've learned some things about how to deal with COVID-19, and maybe learned some things about one of our best doctors and surgeons in the area, Dr. Ed Card. Thanks so much for watching, and we'll see you around. Take care.
Thank you.
Thank you.